Anand, for kind words, and thank you, Alok, for having me an opportunity to meet my friends, and good evening to all. So, not wasting much time, all of us know that CBG improved the outcome of CAD in a way which increased survival in them and event-free survival in them, so that it became one of the most number of operations done, more than gallbladder operations done in the world. And I think it still holds a fort, and it will continue to do so in the future. And in the last 10 years even of my practice and ours practice, the whole population which is coming for CBG is changed. We don't see like 45% ejection fraction nowadays. For me, 35% ejection fraction looks like normal kind of patient for me. Diffuse coronary artery disease, diabetic, uncontrolled diabetics, older population, younger populations, a lot of stents in them, diffuse disease needing endectomy and all that. Comorbidities, you name it, current smokers and everyone. And all of them include a change in our practice. We're sitting at 3% around mortality cumulative. So if you see that 3% mortality and you relate these biases, you have underestimation of this. That 10% of improvement is still minuscule to see. Sitting at 3%, I mean, it's a huge difference in management. And how it has happened, the newer medications, the anesthesia, the short on anesthetic time, ICU care, early extubation, early discharge, and all those things have improved the survival and event-free survival and going to work in productive lifestyle in them. So our idea is now to decrease morbidity in them as well and get the best out of the CABG for longer terms. I will walk you through how the CABG started with vein graft, how the one artery came, that internal mammary artery, and how we came to more arterial conduits to what we call as total arterial revascularization, and why both internal mammary arteries are one of the best conduits to use. What is so unique about these internal mammary arteries, and what is the long-term results and safety about it? So I would say still the definitive treatment of CAD gives most symptom relief, provides best event-free survival. This is old guidelines, but newer guidelines, the SCS doesn't stand with them, the ACC guidelines, but this is the surgeon-like approach. If you have distal left main, if you have any combination with proximal LAD involvement or ostial LAD involvement, or LV dysfunction, or mechanical complications of CAD like MR or VSR or some other aneurysms, you have the surgery as the best treatment modality, and in diabetes. So how we do the CABG? You take a conduit from the body like vein or radial artery. You have to detach both ends. So they are called free grafts. Internal mammary artery is called in situ graft because the origin is connected. You disconnect the distal end and you then join to CAD, the coronary artery. So these are pedicled or in situ grafts. This is how it is started. This is the vein graft, free vein graft. One end to aorta, another end to the LAD. And this is the in situ graft, the lima, left internal mammary artery, connected to subclavian and joined to the coronary artery beyond the blockage. These are rare slides of the same patient. You see the vein graft, you see after 5 years, and you see here gone down after 11 years. And here, if you can appreciate, this is the lima to LAD, the LAD is lima. And after 11 years, it's so pristine, plain, without any disease, and is still filling all collaterals in the LAD. And these are histopathological sites. You see after 12 years, the lumen is patent. The atherosclerosis is almost absent. Here is the vein graft. So this tells you that arteries are better in the system. And this was the seminal paper from Cleveland Clinic, which showed that lima to LAD is going strong even after 10, 11 years, while the vein grafts are going down, mean 8 years or so. And this established that if you put one internal mammary artery to LAD, which supplies 2/3 of the myocardium, you have controlled perfusion to most of the myocardium for a longer period of time. So that made what we call as the gold standard. It's still maybe gold standard in many practices. So one lima to LAD and then other vein grafts or whatever you can do. So this established the improved CABG, and these are the various theories why the arterial grafts are better. So then, as a good providers, we thought, why not more arteries than one? So this is how the alternatives came. In my practice, most of the cases are done by bilateral mammary artery, and I will come down to why we should choose that. These are various permutations, combinations that you can do what we call as total arterial bypass. This is the lima, this is the part of the lima going to the diagonal, this is the radial, this is the free lima to RCA. This is another lima to the LAD and lima to the OM. So left-sided total arterial bypass. I will talk more about this combination. This is called lima, rima, Y. So rima is disconnected, it's a free graft and joined to the side of the rima to create a Y. And what we call a jump or sequential grafting. You can do multiple anastomosis and have the best benefit of the best conduits in that situation, giving longer term benefit by total arterial bypass. And these are the intraoperative images. This grafting technique allows total arterial revascularization to whole heart, more versatile, maneuverable, adaptable, and aortic. You don't touch the aorta. You think about 70-year-old patient who has atheromatous aorta. You don't have to clamp it. Severe risk is so low. And in a reduced situation is much better. Disadvantage is that you have to have a learning curve which is very high. You have to learn that every single anastomosis has to be flawless. I call as zero error operation. And that's why many surgeons do not like it. And you can see the versatility. This is acute marginal PD, and you can have even this revascularized by arterial graft. So BIMA, I say Jeevan BIMA, is bilateral internal mammary artery associated with better short and long-term outcomes. And mind you, my words, incremental benefit with time. Incremental benefit with time. As you spend time, you follow them more than 15 years, the diverge which you see from vein grafts is shockingly different, associated with few drawbacks. And it's not new. It has been done for many years now, but it's still very underused. Only 8-9% all over the world, the surgeons do it routinely in their practice. It may be difficult, yes it is, but while learning, we do 4 cases in a day. You save time than vein grafts. So you have to learn, definitely. It's like driving a Mercedes on a highway on 5th gear or something like that. So you have to learn. So these are some of the things that it may be underused. It's not surgeon-friendly operation, but it has to be learned that way. Factors which make IMA unique. So its physical properties. In our anatomy times, we heard that internal mammary artery has continuous internal elastic lamina. It has less muscular fibers, it's more elastic, it's stretchable. That's why resistant to atherosclerosis. The luminal things do not go in the media and cause medial hyperplasia. The intimal hyperplasia doesn't occur. It provides the adaptability so that, and we know from Bernoulli's theorem, that even a small rise in radius increases flow through that conduit enormously. So it increases in size over time. And when a small increase increases the supply through this vessel. It's a living graft. It's a living graft. The physiological properties. The intima is very active. And apart from any other peripheral artery, like radial, femoral, and all that, it supplies per square area, per unit area, more nitric oxide and other intimal related relaxing factors. And that is why the down in coronary bed, these agents prevent the spread of coronary artery disease further. So it protects the bed from further atherosclerosis. And what I call as drug-eluting, natural, godsend, responsive conduits. So mark my every word. This is how it has been given to us by nature. And we see the patency at 10 years more than 95%. And RIMA is its sister, same. And in OM, it has more than 85% patency, LIMA and RIMA. is much, much more than radial artery in SVG, which has around 60 to 70% patency. So the importance of a living conduit, living and responsive, drug-eluting, natural drug-eluting conduit. So does this excellent graft patency translate to clinical result? Oh yes. Excellent graft patency, relief of symptoms in 98% patients. And you have so low reoperation rate, 1% at 7-8 years. That we're talking, better long-term survival, event-free survival. Cleveland Clinic, they have this. And second decade and still widening. You must have had papers saying that radial is okay, PCI okay with CABG and all that. But the follow-up is 5 years. So the catch is that you have to follow more than 10 years to find the benefit of second arterial conduit, that too IMA, by more than 10 years. If you don't follow them at least 12 years, you don't have the benefit. So even in all patients of LV dysfunction, non-cardiac morbidities, they have significant benefit. Another propensity measures with 30 years follow-up. BIMA favored women, elderly, diabetics, LV dysfunction, pre-op renal dysfunction. All these patients, those who have different subsets, back substrate for this thing. Safety, it is safe. It has early, better short-term risk because vein grafts go down within 30 days even. This doesn't. And it's not predictor of deep-seated wound infection. In diabetics, it's favored because they have diffuse disease, smaller coronaries, and in them the redo operation is difficult. The first time operation should be the best possible, and they have distal bed which is protected by this combination. And as I said, they are made for each other. The off-pump CABG, you don't have to clamp the aorta. So less risk of CVA. In our series, the CVA is only because of AFib. You can do endarterectomies this long. You can remove stents and still do this. And somewhere we have selected population where we will not do this. These are some of the results. Other benefits which patients expect and are happy about. I have some of the results documented in BLK. So you can see that on pump is only 1%. I see 30%, less than that ejection fraction within half patients, half of the population. You see diabetes mellitus, 42% patients. We don't see hemoglobin A1C about that. You see LMCA cases. IBP only 17 out of so many. 30-day mortality 1.44%. Blood product usage very low. And generally 5, 4, 5, 6 grafts. And you see endarterectomy 12%. Re-exploration so low. You have ejection fraction increase. So this I would say should be the norm in today's time. With that, I think I must have been able to tell you something about why arterial grafts, and out of those arterial grafts, why internal mammary artery graft. So I thank you so much, and really I thank you, Alok, for giving me this opportunity.